Now I'm going to take a second to introduce our speaker, Dr. Reeves. Brandi Reeves is a physician scientist specializing in myeloproliferative neoplasms, or MPNs, bone marrow failure syndrome, lower risk myelodysplastic syndromes, and clonal hematopoiesis. She leads her MPN program, which was established in 2019 and provides clinical and research expertise for MPN patients. Dr. Reeves' research primarily focuses on mechanisms of thrombosis in MPN with the goal to improve MPN care by individualizing thrombosis risk stratification and by finding better treatments to prevent thrombosis. She's also dedicated to training the next generation of physicians and is involved in medical student, resident, and fellow education. I'm sure you can see why we're excited to have her on today and why she is perfect for our topic. So with that, I'm going to go ahead and turn the presentation over to her.
Thank you so much, Mary. There we go. So, as you have already heard, MDS and MPN are a mouthful. And even though there are 3 short letters, they get very confusing. So my goal today is to clarify a little bit the alphabet soup that is these diseases. So first, I don't practice in a vacuum. I have a huge team who helps me, and this is my MPN team. And there were too many folks to put on the leukemia MDS team, but they're led by Dr. Joshua Zeidner, who's got a ton of clinical research trials and now some basic science studies ongoing. So if you need medical expertise for any of these diseases, feel free to reach out to us here at UNC. So over the next few minutes, we're going to talk about kind of 3 basic things. We're going to talk about definitions of MDS and MPN, some similarities between these diseases and differences between these diseases, and ultimately the why we care about the differences and similarities. So first, what exactly is it that we're comparing? So the full name for MDS is myelodysplastic syndrome, and the full name for MPN is myeloproliferative neoplasm. So first, let's start breaking these words down to understand what each of them are. So for myelo, it's actually short for myeloid. And in our bone marrow, all of our blood cells actually start from a single stem cell, and that stem cell then ultimately divides into 2 big types of cells. On the left are myeloid cells, and on the right are lymphoid cells. In myeloproliferative and myelodysplastic syndromes, we're talking about the myeloid compartment. So that includes the platelets, the red blood cells, and then white blood cells that are involved in the immune response and allergic responses. Everything else over here on the right is lymphoid, which is involved a little bit in the immune system and in antibody responses. These cells, the progenitors, are in the bone marrow. And as those cells grow up and become mature, these cells go out to the bloodstream. So in the bloodstream, you should not find immature cells. You should always find mature cells. So the platelets, the red blood cells, and then these mature white blood cells. So what do these cells do? Well, red blood cells carry oxygen, and they're measured on our blood tests by the measurements called RBC, or red blood cell count, HGB, which is hemoglobin, and HCT, which is hematocrit. The neutrophils are a type of white blood cell that fight infection, and they're measured on the blood count by something called the ANC, or absolute neutrophil count. And then the platelets really help to stop bleeding, and on the CBC, they'll be called PLT, or platelets. So in myelodysplastic syndrome, in the bone marrow, the stem cells acquire a mutation, ultimately retarding the natural maturation of those stem cells. So you don't get normal production of red blood cells, of white blood cells, especially neutrophils, and of platelets. So ultimately what that can lead to is decreases in your blood count measurements. So decreased hemoglobin, hematocrit, neutrophil count, and platelets. And also curiously, because there's a problem with maturation, you end up with large red blood cells, and that's measured by something called the mean cell volume, or MCV. And the dysplastic feature of this can lead to abnormal looking white blood cells or abnormal looking neutrophils. So instead of having these nice 3 lobes or 4 lobes in there, sometimes they'll only have 2 lobes and they won't have so many granules in them. For proliferative, as in myeloproliferative neoplasms, very similar thing happens. There's a mutation that's acquired by stem cells in the bone marrow, but instead of this leading to decreased production of cells, it actually leads to increased production of normal appearing mature blood cells. So now you have too many red blood cells, too many white blood cells, especially neutrophils, and too many platelets. And if you look under a microscope, there's really not usually a whole lot that can tip us off to the fact that this is a myeloproliferative neoplasm, other than the blood cell counts themselves. So then what about the last piece of these words? So syndrome versus neoplasm. Well, it turns out that both myelodysplastic syndrome and myeloproliferative neoplasms are myeloid neoplasms, which just means that they're caused by an acquired mutation. So you're not born with these mutations, they're gained over time. And why one is called a syndrome and one is called a neoplasm, it actually turns out that back many years ago, the myeloproliferative neoplasms were actually called myeloproliferative disorders because we did not have the technology to understand that there was a genetic mutation that was going on. Same thing with myelodysplastic syndrome. So back when we were first describing these diseases, what we knew was that the cells didn't look normal, and so we called that dysplastic, and the name myelodysplastic syndrome has stuck over the years. In 2005, myeloproliferative disorders was reclassified to myeloproliferative neoplasms because we found a mutation that was underlying the majority of these myeloproliferative neoplasms. And so what's curious is that when we classify MDS and MPN, we have some distinct and separate diseases. And then we also have some that overlap with features of both MDS and MPN. And so there are a bunch of different subtypes of myelodysplastic syndromes these days. And there are several types of MPN. There's the chronic myeloid leukemia, or CML. Then there's the polycythemia vera, which is shortened to PV, essential thrombocythemia, which we shorten to ET, and primary myelofibrosis, which we shorten to PMF. And the big disease that overlaps these two is called chronic myelomonocytic leukemia, or CMML. And that has features of both dysplastic cells in the bone marrow and also proliferative with too many blood cells in circulation. And so in terms of similarities between MDS and MPN, so we mentioned that they're both caused by acquired mutations. So again, these are not things that you're born with, but things that happen over time. And for the most part, the things that cause the mutations are just bad luck, but in some cases, exposure to radiation may lead to these mutations. For myelodysplastic syndrome, more so than MPN, exposure to prior chemotherapy or to solvents like benzene can lead to the mutations. And they both have bone marrow with increased numbers of cells. And so if you're 50 years old, the rule of thumb is that 50% of your bone marrow is fat and 50% of your bone marrow is cells. If you see an increase in that, then there's some reason that your bone marrow is trying to do that. So either it's trying to keep up with production, or it's gotten a mutation and those cells aren't effective in making the blood cells anymore, like a myelodysplastic syndrome, or there's a mutation that's acquired that causes the proliferation of these cells. Both of these can also progress to acute leukemia, which is the feared complication. And they progress at varying rates depending on the type of MDS and the type of MPN. Curiously, inflammation is a hallmark of both diseases, although the inflammation is slightly different in each disease. But it's thought that the underlying inflammatory state is actually what allows for the growth of the mutant cell within the bone marrow. So it kind of creates its own nutrient pool that selectively feeds the mutant stem cell. And this inflammation not only drives then the progression of the disease in the bone marrow, but can also lead to fatigue, which is a hallmark in both MDS and MPN. And fatigue can also be because of anemia in myelodysplastic syndrome. And curiously, bleeding can be seen in both of these diseases. In myelodysplastic syndrome, it's usually because the platelets are low. And in myeloproliferative neoplasms, it can actually be because the platelet count is way too high. And so there's this interesting paradox that too low platelets can cause issues and too high platelets can cause issues. And while we would normally think that the too high platelets would be clotting, it turns out that it's in fact usually going to be a bleeding manifestation. So similarity between the two here. In terms of differences, the main differences between MDS and MPN are that the mutations that lead to these diseases are different. So for MDS, here's another alphabet soup of mutations, but you can see that they typically are different than the mutations we see in MPN. In MPN, it's typically 3 big mutations. And these mutations all lead more towards the proliferation of cells rather than the arrest and maturation of those stem cells. And again, we've gone over this, but the big difference in blood cell counts is that in myelodysplastic syndrome, the cell counts are down while the red blood cells are large. And in MPN, usually the cell counts are up. And curiously, the size of the red blood cells is usually normal or a little bit low because they actually have some issues with iron handling. Now, one of the caveats here is that there are several kinds of myeloproliferative neoplasms. So the subtype called myelofibrosis, or MF, actually looks similar to MDS in some ways, in that it can have anemia, so the low red cell count, the low hemoglobin, low hematocrit, and can also have low platelet count, but typically has an elevated white blood cell count and looks proliferative overall. Curiously, in myeloproliferative neoplasms, there's often a tendency towards an enlarged spleen, which can lead to symptoms such as feeling full after just a few bites of food, or kind of pain in the left upper quadrant, so just under the ribs on the left side. We can see enlarged spleens in myelodysplastic syndrome, but it's way more common in myeloproliferative neoplasms. And then in MPN, we tend to see an increased risk of blood clots, such that about 20% of patients have a blood clot by the time they're diagnosed with an MPN, and about 25% will have a blood clot diagnosed after their MPN diagnosis. And there's a slight increased risk for blood clots in myelodysplastic syndrome, but it's definitely not to the same level as that we see in MPN. When we think about prognosis of these diseases, they are very heterogeneous. So some myelodysplastic syndromes and myeloproliferative neoplasms can have a survival that is close to normal, whereas some have a very shortened survival measured in just a couple of years. And when we look at the scoring systems for these diseases, they're also different. So for myelodysplastic syndrome, we're predominantly now using this calculator called the IPSS-M, which is a molecular calculator that includes information not only about the percentage of early blood cells called blasts in the bone marrow, but also the hemoglobin, platelet counts, age, and then molecular data. And similar, the MPN score that we prefer now is called the MIPS 70. We're looking at very similar things. What are the blood cell counts? What are the blast counts or early blood cell counts? And then in this one, we're looking at another feature of the bone marrow, symptoms and mutations. So the scoring systems are very similar, but they're also different because we're looking at different diseases. And since we mentioned blasts, what are those? Well, blasts are the most immature blood cells. And in general, those immature blood cells should stay in the bone marrow until they're mature. And when they're mature, then they're allowed into the bloodstream where they can function normally. If you find immature blood cells in the bloodstream, it usually means that you're under extreme stress. So somebody in the intensive care unit who is very sick, or there's something going on in the bone marrow, and it's usually an infiltration like an MDS, an MPN, or something like an acute leukemia. And the number of blasts in these diseases can change over time. And the phrasing that we use for what the blasts mean in MDS and MPN is different with each disease. So in MPN, we consider no blast up to 10% blasts, chronic phase. We consider 10 to 19% accelerated phase, meaning it's moving towards acute leukemia. And over 20%, we would call that acute leukemia. Whereas in MDS, we have a more liberal classification where if you have 5 to 10% blast, we call it excess blast, meaning it's more than we would expect to see and has a higher potential to progress to acute leukemia. And now, if you have greater than 10% blasts, we call that acute myeloid leukemia. So we have different thresholds for calling this acute leukemia currently between MDS and MPN. And then kind of the general treatment overview, really, even though these are two different diseases, largely our treatment is based on what are your symptoms? Are you anemic? Is your spleen large? Are you having night sweats? And what's the risk of transforming to acute leukemia? So currently our only curative treatment for both disease is an allogeneic stem cell transplant where you get stem cells from somebody else to replace your own. And because that's risky, we are more willing to take that risk if there's a higher risk of progressing to acute leukemia. So if your overall survival is lower, then we're more likely to take the risk on an allogeneic stem cell transplantation. And kind of thinking about what a stem cell transplant is, if we consider your bone marrow to be your yard, and you want these, you want a nice grassy yard, you don't want weeds, and you have a dandelion here, you know that you can go through and mow and cut off the top of the dandelion, but it's going to come right back. So what most of our therapies do would just be like mowing. So we can trim the cell counts down, but we don't get to the roots. But what stem cell transplant does is we end up giving poison and we kill all of, so we kill everything. We kill the grass, we kill the dandelions, and then we replant the seeds that we want. And in this case, those seeds are stem cells from somebody else. And then we have to wait for some time to let the grass grow. And hopefully when it grows back, it's all just grass and there are no weeds left. And then you're cured. But as you know, there is a danger period that the grass won't grow back and you need to do things. You're at risk, for instance, for bleeding and for infection in this time frame. So because of those risks, we tend to reserve this for the highest risk patients. And so this was short and sweet and kind of just a big general overview of what MDS and MPN are, and they're both myeloid neoplasms. But it's really important to distinguish between them for us for prognosis and treatment, as well as just to continue to understand what causes them and find new therapies. So what we've learned over the last decade or two is that there are different mutations that are driving these, which has allowed really targeted therapies for each disease. And I think we're going to continue understanding the nuances. And when we compare the two together, we learn right about what's going on in the myeloproliferative neoplasms that might allow us to alter the stem cells in myelodysplastic syndrome and allow them to grow better. And we learn things about myeloproliferative neoplasms from the MDS setting, where we might be able to modify the programming of the stem cells to make those cells not get out into the bloodstream so well and cause the issues that they do. And with that, I'll wrap up and take any questions that you have.
Thank you so much for that presentation, for being willing to share. I feel like I learned a lot and that helped clarify things for me, so I appreciate that. Like Dr. Reeves just said, now it's time for our Q&A portion of the event. If you have any questions about MDS or MPNs or anything Dr. Reeves spoke on today, now is your chance to ask her your questions. We specifically set aside this time for community members to get a chance to talk to our incredible presenters. So please feel free to ask her any of your questions if you have any. As a reminder, you can ask a question by making a comment and typing it in the chat box, or by raising your hand if you want to ask your question verbally. While we wait to see some questions come in, I had a question about that diagnosis. So what kind of diagnostic testing is required? Is it the same for both diseases?
That's a great question. So technically, yes, it is the same for both diseases. So myeloproliferative neoplasms can be a little bit easier to diagnose because we get those mutations off of the bloodstream. So technically, for a couple of these diseases, if your cell counts are high enough and you have the right mutation, we don't need a bone marrow biopsy. Now, for myelodysplastic syndrome, we generally need a bone marrow biopsy because the cells that look abnormal tend to be the earlier stem cells. And so we can get the mutation information off the bloodstream, but that doesn't exactly tell us what's going on, so we need the bone marrow biopsy. We also need the bone marrow biopsy if we are concerned that there are increased blasts in the bone marrow. So if we're trying to figure out, is this just kind of chronic phase disease, or are we in this more accelerated progression towards acute leukemia? And so in those cases, we'll do a bone marrow biopsy where we put a needle a little bit bigger than the one we use to draw blood into bone marrow section. So we usually get that from the back of the hip where there are no major nerves and no major blood vessels. And if you've ever had dental work done, it's very similar. So we're going to clean the skin up, we're going to numb it up with lidocaine, and then we're going to insert the needle through the skin into the bone itself. And bone marrow, if you've ever seen a soup bone, it's the pink stuff in the middle of the soup bone. So when we put the bone marrow needle in, we're going to take a little liquid portion first, and we're going to send that off for some fancy testing. And then we're going to move the needle, but in the same hole just a little bit, and we're going to get a toothpick-sized sliver of bone out that we can actually look at under the microscope and see how the cells are laying in relation to one another.
And what is there, sometimes there's a risk of, misdiagnosis between diseases. Is that something that commonly happens between MDS and MPNs, or is it usually pretty clear?
Yeah, so that's a great question. So even though I presented it as being, right, MDS and MPN, a lot of times falls in that middle gray zone. So if you think about the Venn diagram, there's a lot of overlap between these things. And especially if the cells get multiple mutations, they can look dysplastic, but also have proliferative features. And so absolutely, they tend to be a little more difficult to treat if they have features of both. It's an absolutely great question.
We have a question in the chat. They say, thank you, great and informative talk, and I agree with that. And then they say they're wondering how you feel about the disease's treatment in the near future.
Yeah, so even though these are quite different diseases, what's kind of interesting is that when you look at the therapies that are coming up for both diseases, many of them are similar and overlap, so that they're hitting pathways that are kind of common to the stem cell maturation and progression. And so I think the things I'm most excited about you probably all recently saw that imetelstat was FDA approved for anemia and lower risk myelodysplastic syndrome. So we finally have something else for anemia, which is super problematic in that disease. We have what I think are hopefully going to be disease-modifying therapies, especially in myeloproliferative neoplasms on the horizon, where perhaps we're able to reduce the number of mutant stem cells and ultimately halt disease progression and maybe even get this disease down into what we call molecular remission, which would be absolutely fantastic. So I think what I'm most looking forward to in treatment is to move away from stem cell transplant with all of its complications and issues, and be able to have therapies that don't have a ton of risk and side effects that can actually modify these diseases. And I think we're on the precipice of understanding the diseases enough to be able to do that.
Thank you. That drug approval was really exciting, and I agree. It's exciting seeing these diseases getting some traction in terms of treatment and treating the anemia, which is such a burdensome symptom for so many people.
Absolutely.
We have another question. After a successful allo stem cell transplant for MDS with myelofibrosis overlap, what are the statistics for this returning?
Oh, it really depends. So, and I know that you all hate those answers, but it really depends on what the pre-treatment characteristics were and who your donor was, what kind of conditioning regimen you were able to tolerate, how deep of a response you were in before transplant. And so I would love to give you specifics there, but that one's tough because there are so many variables that go into the prognostication for how well it's going to work. In general, if we're going to do a stem cell transplant, right, there has to be a way better than 50-50 chance of staying in a long-term remission because of all of the potential hazards with stem cell transplant. So in general, if you're a betting person, if we're going to take you on a stem cell transplant, the likelihood is that you're going to stay in remission. But
Another question. You mentioned that if MDS is high risk enough, patients may get an allogeneic stem cell transplant. What about other therapies like chemo medications? Is it common in MDS?
yeah, so for chemotherapies in MDS, so most of the time we call it chemotherapy light. So the main treatment for MDS is something called a hypomethylating agent. So if you think about the brain of the cell, it contains DNA, and that DNA is ultimately what's going to give the cell directions to make things. So how does a cell mature? The mutations that lead to MDS put a block on those instructions. And so there are drugs called hypomethylating agents that can actually take off that block and allow the cells to mature. So that is what we most commonly use, and those really have fewer side effects in terms of standard cytotoxic chemotherapy. Like you don't lose your hair. There are typically not a lot of nausea, vomiting with them. But we do occasionally use conventional chemotherapies, and sometimes we call them intensive chemotherapies that are similar to what we give in acute leukemia. We tend to reserve those, though, if you have a high number of blasts. So if you start to get into that 5% blast range, then we'll start to consider chemotherapy. But often now, it's just going to be the hypomethylating agent, which is outpatient, sometimes plus a pill called venetoclax. And that treatment together has been pretty good at kind of keeping things under control. The problem is it can't keep it in control forever. So that's when we have to think about other therapies like stem cell transplant.
We have another question. Are there alternatives to growth factors for managing low blood counts in MDS?
I think it depends on which blood cell counts. So Absolutely for red blood cells. So, right, we've classically given the growth factor for red blood cells called erythropoietin. Those are things called erythropoietin stimulating agents or ESAs. Now we have luspatercept, we have imetelstat, hypomethylating agents can help. When it comes to low neutrophils, though, that one gets tough. So sometimes we'll try the hypomethylating agents, but they're not always great for the low cell counts. And then for platelets, also can be tough. Sometimes the hypomethylating agents help. Sometimes we have things like lenalidomide. It's a class of medicine called an immunomodulatory agent or IMID. Um, we have occasionally given the growth factor called thrombopoietin in the form of L-trombopag, also called Promacta. But we get nervous when we give certain growth factors because we know the stem cells also see those growth factors. And so it's a great question. I wish that we were getting better at this. I think we're especially the red blood cells we're on to. The other two so far are lagging a little behind, but I think we'll get there soon.
Thank you for all of those answers. It looks like that's all the questions we have for today. So thank you so much again for your presentation, for answering all of these questions and helping us make sense of these two diseases that, like you mentioned, are so similar, but the differences are important. And thank you for helping us to understand those differences.
Sure thing. Thank you for having me.
Before we go, I'd like to mention one of our important programs called HealthTree Cure Hub. We actually just launched HealthTree Cure Hub for MDS this week, so this is our first time announcing it to our community, so I'm excited to talk about it a little bit right now. At HealthTree, we believe that educated patients and researchers create better and faster cures. So HealthTree Cure Hub empowers patients with the knowledge they need to actively participate in their health journey while providing researchers with valuable insights from real-world experiences. You can join the 12,000 and counting blood cancer patients who are currently impacting their outcomes while accelerating research in Cure Hub. A little bit of a highlight what it does. Cure Hub can connect you to surveys and studies submitted by disease experts. You can securely connect your medical records to track your disease within one interface. You can discover clinical trials that are personalized to you. You can anonymously connect to genetic twin matches. And lastly, you can gain access to a database of side effect solutions that are provided by other blood cancer patients. You can enroll in Cure Hub by visiting the link at the bottom of the slide. We have a dedicated patient navigation team who can help you through the sign-up process if you have any questions. And I'd like to announce our next upcoming events. On July 17th, we have an event together with our AML community on the role of bone marrow transplant in AML and MDS. Please come with questions you have about transplant. This will be a great opportunity to get some answers. And then another event that I have coming up that I'm excited about is an event in July. We're still working on the exact date, so that will be coming soon. You can watch out in our newsletter for that. And it's going to be on barriers in healthcare with some solutions to those barriers. I'm really excited about this presentation and hope to see all of you at these upcoming events. You can visit the link at the bottom of this screen to register for those. Again, want to thank our sponsors, without whom events like this wouldn't be possible. Those are Bristol Myers Squibb and AbbVie. And finally, I just want to say thank you for helping us to build our HealthTree for MDS community. Please don't hesitate to reach out to me if you have any questions about HealthTree or if you have a topic you'd like us to cover in one of our webinars. We would love to make that happen for you. Also, if you want to share your MDS story in one of our webinars, please reach out. We love to highlight our community members to help others through hearing their experiences from peers. I appreciate you all, and I hope you have a great rest of your day. Hope to see you all again soon.